The Pharmaceutical Crime Podcast is brought to you by the Partnership for Safe Medicines, a nonprofit coalition of organizations focused on the safety of our drug supply. Learn more at safemedicines.org. And now, on to our episode. Welcome to the podcast. Today, we're going to actually not talk about crime. We're going to talk about policy. I know everybody loves that, but even though I love crime. And today, we're going to interview Krystal Weaver. She's the CEO of the National Alliance of State Pharmacy Associations, or NASPA, as we call it. I don't think I've ever said the whole name out loud. NASPA's core membership includes all the state-level professional societies representing pharmacists across the country. NASPA supports the state pharmacy associations with policy resources and helps to spread best practices across state lines. They also work closely with associate members, of which PSM is one, which includes companies and organizations interested in state pharmacy policy. And Krystal is a pharmacist and a lawyer and came back to NASPA earlier this year after spending a couple of years working in a corporate law firm on a wide range of issues, including prescription drug affordability boards, which is what we're going to talk about today. Welcome to the pod, Krystal.
Thank you. Great to be here with you.
Happy to have you, and happy to actually see you back at NASPA after I first met you when you were previously at NASPA, like what feels like, I don't want to date us, a decade ago. So we're going to talk today about prescription drug affordability boards. Can you describe to a layman who's maybe neither a pharmacist or a lawyer what they are?
Sure. So prescription drug affordability boards, or lovingly referred to as PDABs, are state-level entities. We're not talking about federal anything here. State-level organizations that have been developed, run by a board of appointees from the state government who are taking a localized approach with good intentions to make medications more affordable for patients. And more accessible, hopefully, in their states is one of their goals. But to achieve this, they're using their authority to set upper payment limits for prescription drug reimbursement. So that sets a cap on how much insurers or government programs will pay for certain medications. So, yep.
And not all of them are using this tool, the upper payment limit, right? Like, I feel like this is like when someone said to me, I asked about how Medicaid programs work, and they were like, "Oh, you sweet naive man! There's like there's a different one in every state." The PDABs are like that, right?
True, yeah, and right. So there's several different states, and I would say they're kind of at different places in the process. So the state that's furthest along, Colorado, has the upper payment limit, but other states include Maryland, Washington, and Minnesota, and other states are going in this direction. And so overall, the goal is to improve transparency, lower drug prices, and ultimately make medications affordable and accessible for patients. We may disagree over whether the currently proposed policies will achieve that, though.
Well, and they're called prescription drug affordability boards. So I've done some work on research on cost of hospitals and procedures. None of that is within scope of these boards, right? They're not addressing the surprise medical bill that you get, when you leave the hospital. It's just the cost of medicine.
Right, just the medications.
So the upper payment limit, this policy lever, I'm going to call it, it doesn't apply to the manufacturers, though, right? Like, it's not a tool for the board to be able to tell a manufacturer you can only sell your medicine for $10,000 instead of $20,000 for a year's supply, right? It's just for the people in state.
Yep.
Is it possible that, and maybe I'm going to be a little naive, is it possible that the payment limit could be set in such a way that the pharmacy actually loses money? I mean, that's a thing that happens today, right? Pharmacies, with what they get reimbursed versus what they have to pay for medicine.
Absolutely. Unfortunately, it happens a lot. Couple recent examples that are recognizable in the news are like Paxlovid, the antiviral for COVID-19, and a big one, the GLP-1s. Which
that's like Ozempic, right?
Right, for diabetes and weight loss. Pharmacies are constantly losing money on these medications, and The trouble is that pharmacies have to function. They're businesses, they have employees to pay. And when they're losing money on prescriptions day after day, they have to respond to that in some way, just like any market player. And so they might limit availability, they might stop carrying those drugs, um, or have to diversify revenue streams. The easy response would be, oh, we'll just negotiate better rates, of course, which is just in reality rather impossible when we're talking about locally owned little pharmacies going up against market players like PBMs, the pharmacy benefit managers that have such a huge market share that there's just no room for negotiation for these pharmacies. So they basically have to just take what they are given in terms of the contracts. And they can take it or leave it. And if they leave it, 30% of their patients lose access through their pharmacies. So they have to take these contracts as they are. So pharmacies end up not carrying the drugs or relying on things like the front end sales of candy bars and little trinkets they sell or whatever their front end sales look like. And pharmacies, like especially independently owned pharmacies, operate on just razor thin margins. And so when they're depending on front end sales to support their prescription business, which is a vital service for their community, there can be bad consequences. I heard a story just this week about a pharmacy who was struggling, and it was one of these pharmacies that relied on the front end sales to supplement their prescription business. Again, sounds ridiculous, but that is the reality of what happens.
Right, you're in the business to sell candy bars so that you can
Yeah,
afford to dispense life-saving medicine.
exactly. And so a Dollar General opened around the corner from this pharmacy in a rural area, and it just killed their front end sales, and they had to close up shop. And that's what closed the pharmacy. And so these challenges, can result in really serious patient access problems, especially in rural areas.
Well, and I've been looking at this quite a bit. PSM has done a whole report on the overlap we see between the medicines that pharmacy benefit managers under reimburse below cost and what counterfeiters choose to counterfeit. And we're seeing an intersection. The circle is the two circles are the same circle, where you have a medicine that costs, let's say, wholesale $3,000 a month, and maybe does something miraculous like makes your HIV undetectable and untransmittable, which is honestly, for someone who lived through the crisis, it's a modern miracle.
Yep.
But pharmacy benefit managers will reimburse pharmacies $50 less than their cost, and the counterfeiters know this, and so they show up and they'll say, well, would you rather make $20 on it? And the answer is, of course, yes. And that price is not so low as to be too good to be true. Like if it was half price and you were saving $1,000, every pharmacist I know would be like, that's crime.
Yep.
But making $20 seems just enough to actually be believable. And these people have licenses. So I have the same concerns. And that's when I arrived at this hearing that the Colorado PDAB is having on June 7th about Stelara, this psoriasis injectable medicine. I looked at a contract from a major PBM, and they're going to reimburse pharmacies $214 below cost. First of all, that's terrible that you have to lose $214 every time that patient comes in the door every month. But more importantly, does the upper payment limit change that practice? Will it stop the PBMs from doing that?
No. No. The upper payment limit will limit the maximum that they can pay and also what the pharmacy pays to the wholesaler. But the PBMs can still drop down below that, and they certainly will.
In fact, they might cause pharmacies to lose more to make up for the amount of profit that they are no longer making because there's an upper payment limit, right?
Could be.
That would be terrible, and I think that would probably affect access to this medicine for patients in Colorado.
Yeah. It's hard to predict how they'll respond, but historical practice has always been in the downward direction, despite evidence of the costs that pharmacists are faced with in dispensing prescriptions and the cost of their acquisition costs.
One of the things that I've noticed about this is that pharmacists have been telling me that they don't get dispensing fees. So along with losing $214 on a dispense of this drug, Stelara, or any drug, because it seems like they're losing money on a lot of drugs, they don't get dispensing fees. In fact, we published a contract on our website that shows that you get reimbursed at 25.5% below average wholesale price plus $0. They explicitly put in the contract $0 dispensing fees. Even when I get like a pill at the pharmacy for the first time, I talk to the pharmacist and he tells me or she tells me things about taking the medication, when to take it, taking it with food, what to watch out for if I'm having some kind of reaction. But this particular drug is an injectable, which seems like a whole level of complexity above that. And I mean, roughly, like, what are the costs involved in a pharmacy hand holding you through taking a new drug that is an injectable? It's probably pretty significant.
Yeah, absolutely. And it's not even just the patient interaction that is costly, it's the inventory. Holding that high cost drug costs money to the pharmacy to manage the inventory. Keeping it safe in a temperature controlled environment is costly. Paying the technician who entered the prescription in the pharmacy system, the pharmacist who checked the prescription to make sure that it's clinically valid and the appropriate option for you based on your other medications. Identifying what counseling techniques you might need to, counseling points you might need related to administration technique, side effects to watch out for, interactions with other drugs. The pharmacist has to apply all of this knowledge and convey all of that to you in a way that is understandable and that will result in you administering it in the proper way. And all this is very expensive. And they also have to pay rent and keep the doors open and pay the front end staff and keep the lights on and pay for security and all kinds of compliance measures. It's a costly business to get into the pharmacy business.
And they clearly, as we've learned, they can't do that from the money they would make buying the drug wholesale and dispensing at retail at a higher price, because they're actually losing money on that. I don't,
Yep.
I think it was a pharmacist in Minnesota that said this quote that I love, which is that we can't sell enough greeting cards and knickknacks to make
Yep.
up for the loss that we are
Yep.
experiencing. And apparently you can't make money off the drug either to make up
Right.
for the cost of just counseling the patient.
In some states, the average dispensing fee is something like 47 cents.
That's really low. I saw a study from 2020, I think that NACDS did, that said the dispensing costs for a specialty drug, of which Stelara or other injectables, is around $74. That like a pharmacy spends $74. And you point out, like even before it gets handed to me, at least two different people, reviewed that prescription to make sure that it was right for me and there was no interactions and all the other aspects that are complicated.
Right.
I'm honestly really worried about the criminals seeing what's happening in Colorado and deciding to take advantage of it the same way that they've done with other money-losing reimbursements that pharmacies have had to struggle with. And I think that one of the big problems with this is that, except for the Drug Supply Chain Security Act, which will let you do a somewhat labor-intensive but effective trace, pharmacies don't have a really good way of detecting counterfeits, but certainly not for a sterile injectable. They can't open it up and sample it. Like, I don't know any pharmacy that has that capability. I mean, I'm not crazy, right? That's a real problem, right?
Absolutely. Yeah. And, the traditional ways that a pharmacist might detect a counterfeit, the label's a little off, the spelling is a little bit wrong, the color of the pill is a little different. Those all go away if they're, like you described, buying back product that is real, likely not storing it safely. So the product may become inactive or in some other way unsafe for a patient to use, and then selling it back to the pharmacy to re-dispense to another patient. There's no way for the pharmacist to catch that unless they know that the actor is an invalid, criminal actor.
Well, and these biologics are these really complicated giant proteins. They don't look obvious when they've been damaged because they've been allowed to get too hot. It
Right.
still looks like a vial of clear liquid.
The liquid.
but it's completely ineffective. Yeah.
Yep. Yep.
So I have another question, which is about patient access. I feel like there's a real risk here that by under reimbursing pharmacies and not changing that and possibly aggravating that, so the PBMs decide they need to get more money from pharmacies and have them lose more money in dispensing this, we'll have a patient access problem. Have you seen patient access problems from the tinkering of the economics such that pharmacies lose money and maybe decide not to carry things anymore that interferes with patients' ability to get health care?
Yeah, absolutely. The two examples we talked about earlier with Paxlovid and GLP-1s. I mean, pharmacies just can't stay alive if they're losing hundreds of dollars on a prescription, and so instead they'll opt to just not stock it, and that forces the patient to either not have access to it or have to use a mail order pharmacy that may not have safe delivery practices to keep things under temperature control appropriately. And it puts a pharmacy in a really tough position because the pharmacist is a healthcare provider. They want to be in the business of making people healthy. But if they can't keep their doors open, they can't help anybody.
I
So
mean,
it puts you in a tough spot.
it's possible we could actually see patients have to leave the state of Colorado to get a medicine like Stelara or some other medicine that ends up being subject to UPL, isn't it?
Maybe if people are on the border, that's something that they might do. I think more likely it'll be that they're forced to mail order, which is difficult if you're on a medication that's injected and you don't have someone that can be next to you to help you feel good about that medicine. Um, I'm a pharmacist myself. I've had an experience where I had a neighbor, an elderly neighbor who was on an injectable medication, and he was just so panicked about doing it, and just needed someone to give him personal attention to calm his fears and help him figure out how to make it happen. That's the magic that community pharmacies bring to their communities. And so when that's taken away and a patient's forced to go to another provider through the mail that is a disembodied voice over the phone, it's just not the same thing. And so patients lose out on that individual attention, and that results in other losses too, where a pharmacist might pick up on the patient not being compliant or not able to access some other medication or have some other untreated symptom or side effect that you just can't catch when you don't have a personal connection.
Thank you, Crystal, and join us for more. Look on our website for more information about the Colorado PDAB and other PDAB topics that we're concerned about, and we'll see you next time on the pod.